Providing high quality and sensitive breast cancer care is always a challenge. It's particularly a challenge when one is working in a multicultural environment. Today, we're going to hear about this from one of the experts on the topic, Professor Shani Paluch-Shimon, who's the director of breast oncology at Hadassah Medical Center and the chair of Israel's National Breast Oncology Group. Shani, welcome.
Hi, Bruce. Really happy to be here. Thank you for the invitation.
So happy you could join us. Please, let's begin. Tell people a little bit about your professional background and where you grew up and how long you've been in Israel and also about your current role.
So I actually grew up in Australia, in Melbourne, Australia. I'm actually a granddaughter of Holocaust survivors, so it's a very big Zionistic community in Melbourne, and obviously shaped my values. And I made Aliyah over 20 years ago. I did my medical training in Australia, but I did my oncology training here in Israel. I'm currently director of breast oncology at Hadassah and also chairing the National Breast Group.
Terrific. So I've known you for quite a few years now. You're caring for a family member of mine, and I've been able to see up front how you combine scientific excellence, clinical excellence, as well as compassion, and knowing how to work the system, make the system work for your patients. How does that play out in a multicultural context?
Firstly, thank you. We try. So our general approach is a view of a holistic care where we want to provide care that's not just the medical side, but it's patient-centered care. So we want to see the patient. And in order to do that, you really need to try and provide care that's going to take them through from high risk and diagnosis through to survivorship or ongoing care. So it's really helping how do we care for the patients along their journey. And so that really involves multidisciplinary care. That's not just physicians, but also nursing care, psychologists, social workers, etc. And if we want to provide that care in the best way possible, we really need to integrate that with research. Now, the challenges are not just challenges of the financial limitations in the system, which doesn't necessarily provide funding for all of those positions or for all of the necessary programmatic features. But also there's a huge challenge when you work somewhere like Jerusalem, where you have a really challenging demographic. Jerusalem is the capital of Israel, but it is also the poorest large city in Israel. And that is because we have a very large Arab Muslim population of East Jerusalem, and we have a very large ultra-orthodox population. And both these groups that make up over 40% of the Jerusalem demographic actually live under the poverty line. So it's quite challenging in terms of how you provide care and tailor care. And care needs to be culturally appropriate and it needs to be tailored. Now, we've known for many years that there are disparities in providing that care, and we know that there are disparities in diagnosis and outcome, but between knowledge and having data, there's a huge gap. So one of the things that we've been doing the last couple of years is researching the disparities and researching these gaps, because if you generate the data and you understand why the disparity exists, then you're able to tailor your system. So part of tailoring our system, for example, is that you provide a multicultural demographic. You need to try and have a multicultural team, which we try and do. It's not always easy to do, and the last 2.5 years have really made that also quite challenging.
Wow. So let's focus first on the Arab population. What are some of the things that you and your team have done to make the care culturally responsive, culturally appropriate?
So the most important thing to do is to make sure that you have a multicultural team. So you need to have team members who are from, that sector and who speak their language, because it makes it it makes it easier. But also you need to understand that the Arab sector in Jerusalem is totally different to the Arab sector from northern Israel. So from northern Israel, they're usually citizens, they speak Hebrew, many speak English, and many of them have higher education. In Jerusalem, the Arab patients from East Jerusalem are mostly residents, so they still have full access to universal healthcare. They do not speak Hebrew, they do not speak English, and most of them don't have higher education. So you need to understand who you're dealing with and the population. So we try to have team members also in our research team who are from the Arab sector and who speak the language. So that's a really important factor. And in the research, we've tried to understand why there are gaps. So one really interesting finding, which we couldn't have figured out had we not done the research and the focus group, was the understanding that in East Jerusalem, the primary care providers in the Kupot are actually freelancers. Most of them are from the Arab sector. Most of them don't speak or read Hebrew, it turns out. So what's happening is we're providing discharge summaries in Hebrew, which not only the patient can't read, but their primary healthcare providers can't necessarily read with ease. We found this out in a focus group, and then it was like, oh, this is something that we can address. You know, when you have AI tools and technologies sort of really well developed. So this is like, I think on the map for me for 2026, this is something that we can try and solve, and it hopefully will help improve. One of the findings was that our Arab patients are they're not on their oral medications for as long as our Jewish patients. But this could be part of the reason why, because if they can't read the instructions, it's very hard to stick to oral medications.
That's really, really important. Thanks. Tell us a bit about your ultra-orthodox population.
So the ultra-orthodox population is very interesting because they tend to present with more advanced disease, much like the Arab sector, and their outcomes are also not as good as with the Arab sector. However, once they're into the system, they do very well. And when we looked at our psychosocial data and we're assessing their quality of life and well-being, they actually perform very well. They do well and they have very good well-being. So it's interesting to understand that. The other thing that's interesting is that they do have community representatives who are effectively like patient advocates for them. And they really help them work the system, which, for example, in the Arab sector or even in the non-religious Jewish sector, people don't have. So once they have their advocates working for them, it really helps. And they're very compliant with treatment because they come from a culture where they're very compliant to somebody above them in the hierarchy who tells them what to do. So the issues with the ultra-Orthodox population are not issues of compliance or lack of understanding because they have people that help them with that. But the challenges are more that they're coming in probably too late. So there's more work to do in that front. But it is very interesting to see the differences in compliance between the different groups and the differences in the quality of life and mental health.
That's really, really important too. So with the ultra-Orthodox, do you, as the oncologist, is it helpful for you to also interact with their patient representative, their advocate? Are you in touch with the rabbis? Imagine breast oncology is a very sensitive issue. How does that play out?
So it's really interesting because that's a space that's changed dramatically over the last 20 years. When I started as a resident, there was more of a need to interact sometimes with the rabbis because decisions were made that weren't really congruent with the medical needs of the patients. I think there's been a huge progress on that front. So I don't have as much need to speak with the rabbis, even when it's like a complicated case. If it's a woman who is pregnant and has been diagnosed and there's a question of continuing the pregnancy or terminating, for the most part, if we give a recommendation, we get really full backing from the rabbis. So there's less need for that, really, because they've obviously learned and studied the subjects as well. But we do have a lot of work with the patient advocates because one of the features of the Haredi community, the ultra-Orthodox communities, they usually don't have any private health insurance. However, they have these chesed organizations that help give this backup. So they effectively have the equivalent of private health insurance. And we work with these advocates and they can often find funding for drugs that aren't available in the health reimbursement scheme or sophisticated genomic testing. So they help us. And often sometimes when we offer clinical trials, which is such an important avenue and opportunity for our patients, if the patient has more difficult understanding the significance of a clinical trial and the meaning, and they might, because when we think about their schooling education, they don't learn really about science and research, which might happen in a more secular or less ultra-Orthodox setting. So the advocates help us sort of mediate and explain and convey that information. And for the most part, they're very supportive and helping us putting the patients in clinical trials so they don't miss, promising opportunities.
Wow, that's so inspiring. We're going to wrap up soon, but if you have a final sentence or two that you want to leave for our audience, this is the time.
These are stormy days or stormy years for Israel. And also, I listen and hear the very careless use of the words like apartheid. And I think like working in the healthcare system is for me such a strong example of how we are just not, this is not how an apartheid state looks. Apartheid states don't care about their healthcare disparities and they don't want to work with people from other cultures. And really in Israel, it is a microcosm of coexistence and in terms of how we work with each other and care for each other. And it's in all directions. And B, I think the fact that we are doing healthcare disparity research, which I have to give credit to the Breast Cancer Research Foundation, the BCRF in the US, they support our research, is an example that we are trying to close healthcare gaps and promote equitable healthcare. So I think it's an important thing for your listeners to keep in mind.
Excellent, Shani. Thank you so much.
Thank you so much for inviting me today.